Okay, looks like we're ready to go. Hello, everyone, and welcome to our first Essential Tremor Virtual Education Forum. My name is Patrick McCartney. I am the Executive Director of the International Essential Tremor Foundation, and our topic today is going to be diagnostic and treatment options for essential tremor. So before we get started, though, I'd like to thank our corporate partners who made these presentations possible. I want to say thanks to Medtronic, Insightec, Steadyware, and Sage Therapeutics. So with their support, they allow us to continue to promote our mission as an organization to provide hope to the ET community through awareness, education, support, and research. So thank you again to them. I want to introduce our first speaker today. Our first speaker is Dr. Avram Fraint. Dr. Fraint graduated from Rush Medical School in 2012 and completed his neurology residency at Rush in 2016, then a fellowship in movement disorders with a focus on deep brain stimulation at Rush from 2016 through 2018, where he was trained by our second speaker today, Dr. Leo Verhagen. He started working at Northwestern and primarily at Lake Forest Hospital in August of 2018 and is now director of Northwestern's Advanced Therapeutic Program. He sees all type of movement disorder patients with a focus on DBS. So Dr. Fraint, I'm going to turn it over to you and let you share your screen for your presentation.
All right, thank you, Patrick, for that introduction, and also thank you to the IETF for having me speak. It's too bad we couldn't do this in person, but I'm glad that we are able to make do, and I hope this is a helpful lecture and piece of information for the ET community. So, like Patrick said, I work now at Northwestern after doing all my training at Rush, and I'm going to really discuss how we diagnose essential tremor, or ET, and then we'll talk about non-surgical treatments for essential tremor, and then that'll be, I think, a good segue into Dr. Verhagen's talk about the surgical options. So essential tremor, or ET, is the most common movement disorder. It's actually the most common cause of tremor. Worldwide, the estimated prevalence is about 1%. But that prevalence goes up to around 5% in adults over 60, and obviously the incidence increases with age. For the most part, we think that there's similar prevalence in males and females, although there are definitely some studies that show a slight male predominance. We think that ET is likely a spectrum of related disorders rather than a single disease entity, and the reason we think that is because there's such a wide range of clinical features, but also of genetic features. We know there's a very strong genetic component. Depending on what you read, there's a family history present in 30 to 70% of ET cases, and that goes up to as high as 80% if the onset is before age 40. So first-degree relatives of patients with essential tremor are at an increased risk of developing ET themselves, and in particular, if that relative develops symptoms at an early age. Interestingly, they've actually looked at pairs of identical twins, and when one twin has essential tremor, it's not always the case that their identical twin also has essential tremor, which is interesting because obviously their genetic material is identical. So that seems to point at least in part to an environmental role, or maybe some other factors that are just beyond genetics alone. There are definitely some high-risk genes that have been identified associated with essential tremor, though not every patient with essential tremor necessarily carries one of these genes. And then the neuropathology, or in other words, what goes wrong in the brain to cause symptoms of ET, is not greatly understood. It does seem, however, that it's general consensus that there's structural abnormalities in a part of the brain called the cerebellum. The cerebellum is this kind of bottom part of the central of the brain here, and it's responsible for lots of things, but chief among them, balance, coordination, clarity of speech, eye movements, things like that. So what does essential tremor look like clinically? Well, classically, it's considered an action and a postural tremor. That is, it's activated by voluntary movements or when the arms are held in a fixed posture against gravity. So things like drinking and feeding can be very difficult. And it really, again, classically should be absent when that body part is at rest. But of course, there's patients for whom their tremor is strong enough that even at rest, there is a little bit of tremor. We call that overflow tremor. But the predominant tremor is the action and postural tremor. It's usually present in the hands or in the arms, but we sometimes see it in the head, in the voice, in the face, in the trunk, or even in the legs at times. It's usually bilateral. That is, both sides of the body or both arms, for example, are affected. It can be symmetric or asymmetric, and that's an important distinction because we think of Parkinson's disease, for example, as classically being an asymmetric disorder, and essential tremor, while not always exactly equal on both sides, we think of as being less asymmetric when we compare it to Parkinson's disease. It's considered a moderate to high frequency tremor, so between 6 and 12 hertz, although there's considerable variation there. And the amplitude, or how big the tremor is, can vary significantly as well, from low to high amplitude. There's often head tremor, which can be yes, yes tremor or no, no tremor. And then when there's head tremor, there's often tremor elsewhere, right, in the hands or the voice. And it's important to make the distinction here that isolated head or vocal tremor is, I put exclusionary in quotes, exclusionary for essential tremor. So if the tremor is really just isolated in the head or in the voice, then that makes you think about maybe another diagnosis, specifically something called dystonia or dystonic tremor. One of the things that you learn about essential tremor in medical school are the things that make it better or worse. So classically, it's worse with stress, with anxiety, in states of high adrenaline or high excitement. Some people say there's certain foods like chocolate or that can make it worse. Pain, lack of sleep, really anything that kind of revs up the system can make tremor worse. And classically, it's improved by alcohol and then avoiding all the things that might make it worse. So if you look at this figure I have here, these are the Archimedes spirals. This is one of the ways that we test tremor. And you can see the spirals on the left are much more tremulous compared to the spirals on the right. And, you know, there can be variation in even something like Archimedes spirals depending on if you're in one of these kind of high tremor or low tremor states, because, you know, tremor by its nature for many people comes and goes. So it's important to kind of identify things that might make it worse and avoid those things. We certainly don't recommend self-medicating with alcohol on a regular basis. So the rest of the physical exam really should be normal in essential tremor. Tremor should be the only abnormality on the exam, although there are some exceptions to this. And this was actually one of the questions that was presented to me is that, you know, do some people with essential tremor also have balance issues? And the short answer is yes, they do. They often have problems with tandem gait, which is kind of the field sobriety test gait where you walk with one foot in front of the other. And likely that relates back to the slide about the neuropathology of essential tremor, in that the cerebellum is the part of the brain that's implicated in causing the symptoms, and the cerebellum is responsible in large part for balance. So it makes sense to me anyway that if someone has a cerebellar issue causing tremor, that they would also potentially have balance issues. And then there's this category of, quote, late onset essential tremor, which I'll touch on in a bit. And we think those patients might be at a slightly increased risk of developing some cognitive impairment down the line. So here's a table that I thought is for me is helpful anyway, because often what happens is patients come in for evaluation of tremor, and really what they want to know is, do I have Parkinson's disease? And so one of the, you know, these are various ways that we differentiate the tremor of ET from the tremor of PD. So again, usually the ET tremor is considered symmetric, or more correct, I think, would be to say less asymmetric compared to Parkinson's. The predominant tremors in ET are postural and action. There can be rest tremor, but usually it's not as significant as the postural or action tremors. Whereas the Parkinson's tremor, the classic tremor for Parkinson's, is a resting tremor, which actually improves or goes away when patients lift their hand to use it. And then there are other symptoms of Parkinson's, like stiffness and slowness, that should not be present in essential tremor. If those things are present, then that should push you away from essential tremor. And then I mentioned ancillary findings of Parkinson's disease. These are things that happen in Parkinson's that are not required for the diagnosis, but when you see them, they are supportive of that diagnosis. And so if you see those things in someone who otherwise looks like essential tremor, it should just, I think, give you pause before you kind of offer a diagnosis. Over time, essential tremor is typically very slowly progressive. What I often hear is that patients say, oh, I've had symptoms for many years, they never bothered me, but really in the last 6 months or 18 months, 2 years, things have gotten really bothersome for me, and so I just wanted to get it checked out. And then over time, we find that tremor will move from one part of the body into another. And I think calling it a, quote, benign essential tremor is really just poor branding, because lots of patients will say that, even though it's considered a benign tremor, it does cause a significant negative impact on quality of life. So I wanted to just kind of briefly talk about this one article, because this was published a few years ago in the Movement Disorders Journal, and this is something that, for me, I kind of think about when I'm seeing new patients with essential tremor. So one of the things that was interesting about this paper is it identified 2 different peaks of when tremor might start, and then there's this early onset group. These are patients who develop tremor at age 24 or younger, and then the late onset group is that includes patients who develop tremor around age 46 and over. And this is the paper that identified that these late onset patients might be at a higher risk for developing some cognitive decline. Other specific differences between these 2 groups, and the next 2 slides are basically just going to show the same thing. But if you look, this column on the left, this is the early onset, and on the right, the late onset patients. And if you look here, early onset patients are more likely to report alcohol responsiveness, so 76% in early versus 45% in late. And then similarly, the early onset patients were more likely to report a positive family history compared to the late onset patients. And again, here is just the same data shown in a histogram. So on the left, we see this is the family history histogram, and on the right, this is the alcohol responsive tremor histogram, and you can see that the white bars here are much higher. So again, the young onset ET patients are more likely to report a positive family history and alcohol responsive tremor. So then just kind of getting back to how we think about these patients when we see them in clinic, how do we work them up? So in other words, how do we approach or arrive at a diagnosis? So the number one thing is a very detailed neurologic exam. We look at the tremor. We make sure that there's no evidence of things like Parkinsonism or other potential etiologies. And then the next important thing to do is look at the patient's medication list, because we know there are many medicines that can cause or worsen tremor. So these should be addressed. There's definitely lots of psychiatric medications, for example, that can contribute to tremor. And what I typically tell patients is, if you're psychiatrically stable, my preference is usually to keep things the same as far as those medications. But if it's something that can be easily changed, it's a discussion that I think should be had. Then we check some blood work. We look to make sure the electrolytes are all in good order. We check the thyroid. In the appropriate clinical context, we might check for something called Wilson's disease, which is very unlikely, but it's the kind of thing that you would check for if again, in the appropriate clinical context. I routinely do not order MRI brains for all these patients because this is a clinical diagnosis, and even in Parkinson's and essential tremor, the same. The MRIs are almost by definition normal, so unless there's something on the physical examination that pushes me to ordering imaging of the brain, I don't typically order that routinely. There are, established diagnostic criteria that the International Parkinson's and Movement Disorder Society Task Force published. These include isolated tremor consisting of bilateral upper limb postural or action or postural tremor without other motor abnormalities. So again, like we mentioned before, basically tremor without any other physical exam abnormalities, at least 3 years duration, with or without tremor in other locations, and no other neurologic signs like dystonia, which I touched on before. That's kind of abnormal and involuntary muscle contraction that can cause abnormal postures of the muscles that are involved, but also some tremor, ataxia, which is kind of a balance and coordination problem, and then Parkinsonism. So a lot of people also ask me about DAT scans. The DAT scan is basically a special scan where an IV is placed in the arm, and then the tracer is injected through the IV, and it should bind all the dopamine-producing cells. And in diseases like Parkinson's and related disorder, when you're not making as much dopamine, then the uptake of that tracer should be decreased. And so it is helpful in diagnosing whether or not there's Parkinsonism, but it doesn't get at any specific diagnosis. And again, Parkinson's and essential tremor are both clinical diagnoses, and so I do not routinely order DAT scans because it really does not change my management at all. But I guess in some situations where you see somebody over multiple evaluations and it's still not so clear, am I dealing with essential tremor? Am I maybe dealing with Parkinson's disease? Then maybe there is a role for a DAT scan, but it's not something that I routinely order in my ET patients or in my Parkinson's disease patients. So then moving on to treatment. So really the first important question to answer is treatment necessary? Because as I mentioned before, a lot of times all patients want when they come to see me for tremor and they're ultimately diagnosed with essential tremor is they want to know, do I have Parkinson's, or does this mean that there's something more serious going on? And often reassurance is really all that they'll need because the tremor is not very bothersome. So I say this is very much a patient-driven decision because that is the case. I've seen patients with terrible tremor where if it was me, I'd want all the medicine that was available, but they don't like medicine or the tremor doesn't bother them all that much, so they choose not to use medication. And then there's people on the other end of the spectrum where the tremor is extremely mild, but they're very embarrassed by it. It's very socially disabling. It's difficult for them at work, and they want medication for it. And so, because tremor is not unsafe, I really do leave it up to the patients as to whether or not they want to try medications. And then when the patients do decide to opt for treatment, in this case pharmacologic treatment, it's very important to specify or to kind of address expectations. So what should get better with medicine, what might not get better? Generally speaking, we think of midline symptoms, so tremor in the head, tremor in the voice, as being less responsive to oral medications compared to tremor in the extremities. So another way of saying that is tremor in the hands is more likely to improve with medication compared to tremor in the head or the voice, and that is oral medication. So the kind of classic essential tremor medication is propranolol. One of the reasons I like propranolol because it's really basically, with one exception, our only as-needed option because it comes in short-acting or immediate-release formulation in addition to the typical long-acting formulation. So some people use it as a, quote, pill in a pocket where if they're going to do public speaking or go out to dinner, then they'll pop one of these pills prior to eating, and then it's in their system for a few hours, and then it's out of their system after that. It's a beta blocker, so it's actually a blood pressure pill that lowers the heart rate and lowers the blood pressure. And there is good evidence that doses anywhere in the range from 60 milligrams a day up to 320 milligrams a day are effective in reducing tremor in the limbs. And then tremor magnitude can be reduced by about 50%. So if you think that this is one of our better oral medications, and sometimes the best you can expect as far as tremor reduction is only 50%, it's good, but it's certainly not great. It probably, according to the AAN guidelines, that's the American Academy of Neurology, it probably reduces head tremor, but that reduction is definitely less robust if you compare it to tremor in the limbs. Like any medication, there's potential side effects. It usually is really well tolerated, but some people get lightheaded, some people feel fatigue. It can cause impotence, bradycardia, which is slowing of the heart rate. It can cause constipation. Because of the cardiac activity, we don't give it to people who have heart block or asthma because the mechanism of action of this medicine sort of counteracts the mechanism of action of the asthma medications, and so they can't be given together. And then in patients with asthma, there's a cousin medication called atenolol, which can sometimes be used and can be effective. Primodone is probably the other most common essential tremor medication. It's an anti-seizure medicine or an anticonvulsant. It's a very old medication. According to the AAN guideline, we can use doses of up to 750 milligrams a day. I definitely have patients that can tolerate that much, but I would say that most patients get side effects before they get up to that dose. Also, limb tremor magnitude can be reduced by up to 50%. So again, not insignificant, but a lot of patients want to get rid of the tremor completely. The mean dose is usually around 500 milligrams a day. One small study of 26 patients, a retrospective study, showed that there can be an improvement in vocal tremor with this medication. I've personally not been too impressed with its reduction in vocal tremor. And then the side effects for this medication, they do typically happen more when the medication is first started, but it can be things like sedation, depression, nausea, ataxia, or balance issues. And then it's important to know that this medicine should not be given along with anticoagulants because it can make the efficacy of the anticoagulants less predictable. And of course, you don't want the blood to be too thin or not thin enough. And so that's an important medication interaction to be aware of. Gabapentin is kind of a pretty ubiquitous medication now in medicine, and particularly in neurology. It's another anti-seizure medication. One of the things about gabapentin that's a little bit frustrating is that the titration is very slow. So we started a low dose, and you've got to give a few weeks before you know whether or not it's been beneficial or whether side effects have developed. You kind of have to very slowly increase the dose. And then gabapentin for tremor is really only effective once you start getting to doses around 1,200 milligrams a day. But I find that many people develop side effects like sleepiness before they can get to that dose. And if you start at that dose too quickly, then you're more likely to get side effects like that. And so, you know, if we do get to that dose, it's usually a very slow ramp up to get there. But for some people, it can be effective. Topiramate is a newer medication that was approved for tremor, and there's decent evidence to use that as well. It's another anti-seizure medication, another medicine that we use for lots of different things in neurology. There were 3 randomized controlled trials that were reviewed in an article in 2017, which showed that there was an improvement in functional disability-related tremor in patients who took topiramate. And then there's a pretty large study, 223 patients, that showed that topiramate at a mean final dose of 292 milligrams a day resulted in a significantly greater improvement in the tremor rating scale when compared to placebo. People who have been on topiramate will probably note here that it's almost impossible to get to doses that high without side effects. So I typically find that people have side effects on topiramate once you get above 100 milligrams a day. So it's just rare that you'll find a patient that can actually tolerate that much. The main side effect that I find that bothers people, so there's paresthesia or tingling in the fingertips. It can suppress appetite, which actually is a reason that some patients choose to use that medication. But a lot of patients will say that there's a lot of mental fog that happens at doses above 100 milligrams a day, poor concentration, poor memory. And I find that's usually what limits people's ability to ramp up doses of topiramate to a dose that might actually be effective in reducing tremor. There are definitely other medicines that we use for tremor, but the evidence for them is not quite as strong or as robust as for the other medications. So one class of these medicines are the benzodiazepines like Klonopin or clonazepam or alprazolam. Now, clonazepam in particular is good for tremor, particularly tremor that responds to alcohol, but I don't like this class of medications for long-term tremor control because they're habit-forming. There's tolerance that develops. So in other words, the longer you take them, the more of them you need to achieve the desired effect. And there can be withdrawal when people try to come off of these medications. Botulinum toxin is another good treatment modality. It's good for, well, it's kind of anecdotally, we use it a lot for head tremor. I was actually kind of interested to find out that the improvement when you look at studies looking at Botox for head tremor, did not reach statistical significance, but I can say that for my patients, it actually reduces head tremor a lot. There are some people that are using Botox for limb tremor as well, like hand tremor, for example. And I think you need a really skilled electromyographer and injector for those, because there's so many different muscles and they're kind of layered on one another, and they're kind of small and not always so easy to isolate. So it'd be really easy to potentially inject into the wrong muscle. And even if you do inject into the right muscle, the mechanism of that medication is to weaken the muscle. So you might be trading one problem for another. You might get rid of the tremor, but you might be left with weakness and still an inability to use that hand. And then finally, there's ear, nose, and throat doctors who will do Botox injections for vocal tremor. And I've seen with my patients that it can be very helpful. There are other medicines that we use for tremor, like amantadine, clonidine, acetazolamide, and mirtazapine. I particularly use amantadine and mirtazapine often. The data for those in essential tremor is not quite what it is for the other medications that I mentioned, but I've definitely had patients who benefit from those medications. And I think at this point, we're probably getting the sense that there's a lot of different medications, and we often just kind of go through each one in some kind of sequence until we find one that works. There's some medicines that might be contraindicated in some patients, and that pushes us toward one medicine over another. But sometimes it's just kind of a matter of going through the different oral medications before we find one, if any, that is helpful at reducing tremor. So I'm going to end with just touching on the non-pharmacologic options. I mentioned DBS and focused ultrasound here only for sake of completeness. Dr. Verhagen is going to discuss those, obviously. I'm going to touch on the wearable device, or really just one in particular. So there's a new device, which is essentially a bracelet. It kind of looks like some of the exercise, like Fitbit sort of bracelets that you can wear around your wrist. And the idea is that if you stimulate the median or the radial nerve, which are two nerves that kind of run underneath the skin near the wrist, if you stimulate those nerves, that can somehow then affect the tremor center of the brain and reduce tremor in the hands. So this was another study published in Movement Disorders in 2018, where 23 blinded subjects with ET were included. And then some of them got treatment stimulation, and some of them received sham stimulation. I can show you what that means. So if you look at panel A, this is what the bracelet looks like. And they position these electrodes appropriately over the median and the radial nerves. And then they had the subjects draw their Archimedes spirals prior. That's the baseline spiral. The treatment group received a 1-minute stimulation ramp up, followed by 40 minutes of continuous stimulation, after which they did the second spiral. And then the sham group got the ramp up, but then the stimulation was turned off for the next 40 minutes before they did their post spiral. So if you look at panel C in the treatment group, you can clearly see that the tremors improve after 40 minutes of stimulation, whereas in the sham group, it even looks like the tremor's a little bit worse. So these are just other panels that show kind of the same thing. Just focus on this black line. That's kind of the overall trend line, which just shows that if you look at this Tetris score, this is just a way that we can sort of quantify the spiral rating. There was an improvement with the treatment bracelet stimulation, whereas the sham group had no improvement from pre versus post. And then the treatment group actually had a reduction in their tremor amplitude as well compared to the sham group. So this is definitely promising data. Here's a similar study. This is a bigger study that included 77 patients with essential tremor, 40 who received the treatment and 37 who received the sham stimulation, also before and after a 40-minute stimulation session. And then there was improvement again in the Tetris score amongst the treatment group. And then interestingly, when you asked the patients to sort of just subjectively report how they felt their tremor was, 88% in the treatment group said they had a benefit versus 62% in the sham group. And the treatment group also enjoyed a larger improvement in activities of daily living scores. So I think when it comes to quality of life, which really is the most important thing. I mean, I'm much more interested in what the patients feel the improvement in the tremor was compared to what the, TETRAS score was. This is, I think, compelling data to, recommend it to our patients. And certainly there's no side effects associated with this kind of thing. So certainly something that I think, or that I hope anyway, is going to be utilized more frequently in the future. So just to kind of wrap up and summarize here, essential tremor is the most common movement disorder. A diagnosis comes through a thorough physical examination, ruling out any other etiologies. It has a very wide clinical and genetic range. Many medications, that is oral medications, exist to help tremor, but unfortunately, benefit is typically incomplete. Wearable devices might be helpful. I think we just need, like for anything, more data. And then I think that's a good segue into DBS and focused ultrasound, because I think these are both really excellent options to help reduce tremor when medications or wearables are just not enough.
Awesome. Great. Thank you, Dr. Fraint.
My pleasure. Thank you.
Couple quick questions for you. What are your thoughts? We get this question a lot to the IETF about CBD or marijuana as a treatment option for essential tremor.
Okay, it's a good question. So the bottom line is there's no indication, there's no evidence that's strong enough to say that the cannabis-containing products are useful at reducing tremor. I believe there's one study out of Israel where they took people with tremor who were already regular or cannabis users, and I think subjectively some of them reported improvement in their tremor, but certainly not like a randomized placebo-controlled trial, which kind of is the gold standard that would be required, I think, to recommend it. I don't think it was going to make tremor worse, but I certainly cannot say with any authority that it's going to help tremor.
And what do you see many patients? Another question we get a lot about is internal tremors and what those are and what can be done about them.
Yeah, I think it can be kind of a very frustrating symptom for many people. We definitely hear it frequently, both in essential tremor and also in Parkinson's disease patients, actually. I find that when we do get improvement in internal tremor, it's with the same medications that we use for the more visible tremor. And I don't think that the pathophysiology would be any different for that internal tremor compared to the external tremor. I just think that, everybody sort of experiences their symptoms differently, and, we use what we have available to us in order to address these symptoms.
Great. Last question. I'm going to ask Dr. Verhagen this question too later, but we also get a lot of questions. Can an ET turn into Parkinson's?
So we think that there is a slightly increased risk of developing Parkinson's disease amongst the essential tremor patients. Now, whether that means we're just kind of misdiagnosing them at first, or whether, it is actually a risk factor for developing Parkinson's, or whether some people just have a dual pathology, which we know happens sometimes with Alzheimer's and Parkinson's disease. You can get more than one tremor-causing neurologic disorder, but we know they're associated. I don't know that I could say much more than that as far as, we can't really predict which ET patients are going to go on to develop Parkinson's disease. I think the patients where I've seen where they have kind of this PD/ET, usually they kind of have the textbook story of essential tremor, lifelong history of tremor, strong family history, worse with stress and anxiety, better with alcohol. And then over time, they start to develop more of a resting tremor, and they have the masked facial expression and things like that. So, to me, that seems like maybe it's an overlapping pathology rather than kind of one specific thing causing both neurologic issues. I'd be curious to see what Dr. Verhagen says about that, though.
Okay, awesome. Well, again, thank you for joining us. We appreciate your time today. We know you're busy. And sorry we couldn't do this in person, but hopefully in the future here we'll get to come to Chicago and do this in person. So again, thanks for joining us, and we appreciate
Thank
your
you.
input.
Thank you. Thanks so much.